topic to test in Nclex, because nurses need to be aware that it is a possible complication with the administration of IV fluids, and that we are responsible of detecting the problem and correcting the problem, which is very simple. Stop administering the fluid. And it is a common condition. In heart failure, okay, the people develop edema. They retain fluids, and the veins are engorged or dilated. The reason for which in heart failure there is a retention of fluid is that the heart is the pump that moves the blood toward the kidneys. Kidneys need to eliminate the excess of water of the body. The same way that they kidneys save water when we are short of water, when we have fluid volume deficit. So in reality, the organs that are responsible of the adequate normal volemia or normal volume of liquid in the body are the kidneys. No? But if the kidneys need the blood and this liquid to be sent under pressure and abundance to the kidneys, if the pump that moves those liquids, that is the heart, is failing, especially the left heart failure, uh, then less liquid is pumped toward the kidneys, less liquid is eliminated as urine, and for that reason, the outcome, the eventual event is retention of fluid. If the own kidneys are damaged, then who is going to eliminate the fluid? So it's too evident, no? And of course, I already mentioned the administration of IV fluids. There are other circumstances in which you can also have fluid volume excess. There are certain hormones that influence the kidneys. Those hormones are the antidiuretic hormone, the do not pee hormone, don't urinate hormone, okay? The antidiuretic hormone, and the aldosterone, yeah. So the aldosterone i- i- is a hormone that tells the kidney, hey, kidneys, don't pee. Also aldosterone, okay, tells the kidneys, don't pee. Sodium and water, I like it. I want that for me. I'm a hoarder of sodium and water. This is what the aldosterone said. Sodium and water for me, keep it that for me. Potassium, I don't like potassium. Potassium for the toilet. Pee the potassium in the toilet, okay? So this is what continuously is saying the aldosterone, the kidneys. If you have too much, you know what means too much, no? When this is not the adequate amount, it's too many, too much, yes? Too much antidiuretic hormone or too much aldosterone, then you can have a retention of urine. Is like no peeing. It's no pee, no pee, no pee, no pee. If you don't pee, what happens? Okay, you retain the fluid. Yeah. So there is a syndrome of inappropriate antidiuretic hormone in which there is too much antidiuretic hormone, and you are supposed to know this syndrome before going to your Nclex, because it was taught in your MedSearch book in your program. And there are conditions in which we have too much aldosterone activity. The best known of all of them is one that you call Cushing syndrome, in which the main elevation is the cortisol, the twin hormone produced in the same place as the aldosterone. Cortisol, okay, the cortisol has the same um, activity as aldosterone. Or people receiving, okay, steroids, okay, glucocorticoids, prednisone. So those people also are going to retain liquids. So it could be, for example, in the list. The most commons are heart failure, renal failure, and administration of IV fluids in excess, of course. But don't forget those endocrine conditions like the syndrome of inappropriate antidiuretic hormone and the cushion or the administration of glucocorticoids that makes the kidneys retain excessive amount of sodium and water, and for that reason can produce fluid volume excess. Probably those are the most common causes that you need to have in mind, and as I said, is tested because you need to know the pathophysiology of all those conditions. So those conditions, those are heart failure, renal failure, excess administration of IV fluids, have in common, certain symptoms. Cushing syndrome of inappropriate antidiuretic hormone have in common certain in common. So what happens when you have too much too much too much fluid in your veins and arteries? Well, you are going to see, for example, that the blood pressure is going to increase. You are going to notice that the strength of the pulse is is increased. So the pulse is very strong. You are going to notice the normal pulse, the pulse that you have, the intensity of the pulse that you palpate in the radial artery is considered 2 plus. So now you are going to have, a bounding or pounding, pulse 3 plus or 4 plus. Yeah. You are going to see that the veins are distended. Veins are distended. Yeah. So you notice this hypertension, strong. The patient is going to gain weight. Because the water has volume, the water has mass, and it has a weight. So the person, when retaining liquids, is gaining weight. By the way, you need to know that 1 liter, is like a quart, of water is going to weigh 1 kilogram. And you know that 1 kilogram is the same as 2.2 pounds, 2.2 pounds, So it is important because this equivalence is what you use to know how much liquid is retaining a person, So if a person from from today till tomorrow is gaining 2 kilos of weight, because you are weighing the person at the same time in the morning, and you notice that is gaining 2 kilos, is gaining 4.4 pounds. Yeah, yeah, and is gaining 2 liters of water, and 2 liters of water is a lot. Yeah. So is another finding in those patients. This water need to be someplace. So usually this water is going to accumulate in the most dependent parts of the body. Usually a person spent, especially a sick person, usually a person spent most of the day, the majority of the hours of the day, sitting or standing. So you are going to see that there is edema in the lower extremities edema together with this. But if the person adopts the recumbent, lying down, position, you'll see that this edema is going to move from the legs to the back of the client, and even is going to go to the chest and to the lungs of the client. So there is a phenomenon that you need to understand with the fluids. It's a physical phenomenon, is that fluids are attracted by the gravity force. So if you are sitting, the person is sitting, the edema is in the legs. So you notice the swelling on the legs. By the way, the swelling in the legs is not going to produce problems to breathe. No problem to breathe if the swelling, it's the liquid is in the legs, because you don't breathe with the legs. That's the rationale. But if you adopt the recumbent position and the liquid, because now the gravity force is going to move those liquids in the lower extremities toward, okay, the trunk, and the liquid floats the lungs, now the person is going to experience problems to breathe when at night, when usually people go to bed. That's why those people, okay, I can present a worsening of the dyspnea, the problem to breathe at night, and it is called paroxysmal nocturnal dyspnea. Dyspnea is difficulty to breathe. Nocturnal means night. Paroxysmal sudden, something that occurs suddenly. Is a person that goes to sleep with swollen legs, but after 2-3 hours of being on bed, the liquid is moving from the legs to the lungs and is waking up with an intense shortness of breath. This is nocturnal paroxysmal dyspnea. I always say that in Spanish, okay? That's why I wrote that the different order, okay? I cannot change my mind. This is the language that my mother taught me. So it's nocturnal paroxysmal dyspnea. This is the way that you say in English. Okay, so it's very important that you understand that. That's why those people to sleep, they are requesting several pillows because they feel better when they keep their chest elevated, and it is called orthopnea. Orthopnea is this intolerance of the recumbent flat position to sleep because the displacement of liquid to the lungs that producing those dyspnea. You know that you can listen to this liquid in the lungs through auscultation, and then you are going to notice that there is moist crackles, especially in the lung bases. And the patient can have cough. The cough is trying to eliminate this liquid that is in the lungs. That usually happens when we have liquids going wrongly to the lungs. But then this cough can become very moist to the extreme that the patient can spit up some sputum that contains this liquid that is in the alveoli, because this liquid is coming from the blood, have few red blood cells. For that reason, the liquid is pink and it's frothy because there in the alveoli, the liquid is combining with the air that the person is breathing, forming a foam. That's why it's a pink frothy sputum, which is the characteristic of what is called pulmonary edema. Pulmonary edema is the extreme of this fluid volume excess that we are talking. And you understand that it's much more severe than having edema in the lower extremities or neck vein distension because you don't breathe with your legs. You breathe with your lungs. It's when the lungs are flooded with fluids is when the situation becomes critical. This is the concept of orthopnea. That's why the crackles. That's why the pink frothy sputums and the cough. Okay. The person is going to experience tachycardia in this scenario. Why? Because it's very simple. Who controls the heart? The love. Some of our students say, the love control the heart. No, the one that controls the heart is the brain. Brain controls the heart. Okay, and when the brain is upset. When the brain becomes upset, well, brain can become upset if there is little oxygen going to the brain. Brain become upset when there is low pressure of blood going to the brain. Brain becomes upset when there is, for example, too much stress, psychological stress. Okay. Yes, brain becomes upset when, for example, there is low blood sugar because brain needs a lot of blood sugar to work. So when you have low oxygen, low blood pressure, low glucose, or too much stress, brains become upset. And when brain becomes upset, activates the autonomic nervous system called sympathetic nervous system, okay? The sympathetic nervous system, the one that works with epinephrine. And this is going to stimulate the beta 1 receptors in the heart. You know, beta 1 in the heart because you have one heart, beta 2 in the lungs because you have two lungs, yes? Okay, the beta 1 receptors. And the stimulation of the beta 1 receptors by the epinephrine, by the sympathetic nervous system, is going to increase heart rate. So you expect increased heart rate when there is low oxygen. And why low oxygen? Didn't we explain that the patient was experiencing a flooding of the lungs called pulmonary edema? Of course, if the alveoli are flooded, yes, and is in the alveoli where the gas exchange occur between the capillaries of the pulmonary artery and the alveoli. This gas exchange is what oxygenates the blood. If there is a flood, okay, in the alveoli, then this gas exchange is impaired, and then you see that there is a drop of the oxygenation. This drop of the oxygenation immediately is sensed by the brain, and the brain becomes upset because one of the requirements of the brain is to have an adequate supply of oxygen. So you expect a drop in the oxygenation of the blood, I mean a drop in the O2 saturation, the pulse oximetry, a drop in the determination by ABGs of the partial pressure of oxygen in the blood, and is part of the syndrome. So can this client benefit from administration of oxygen? Absolutely yes. Absolutely yes. But don't forget that the client has the lung flooded because the position. So please, even before starting the oxygen, sit the client. It is taking, seconds to do that. Seconds. In seconds, you can sit the client. When you sit the client, okay, the lungs now are going to have the liquid move to the lower part, and the upper part is going to be free. It's going to be free of liquid, and the patient will oxygenate better, and then is going to benefit from the administration of exogenous oxygen that will increase the inspiratory fraction of oxygen, okay, the FiO2 of the oxygen, which is going to improve the gas exchange. So absolutely, so understanding the pathophysiology of this condition, also we understand the adequate nursing and medical intervention. So yes, the patient has tachycardia because activation of the sympathetic nervous system, has hypertension and bounding pulses because the excess of liquid inside the arteries, distended neck veins because there is too much liquid in the veins, or orthopnea because the lungs are flooded, the most crackles, even the pink frothy sputum in the extreme cases, at least cough can be observed, moist cough, the dependent edema. But you know that this edema is going to change depending of the position of the client. It's not the same to be sitting than being recumbent or lying down in bed. The weight gain, okay, the weight gain that we understand. So please teach your clients that suffer of heart failure, that suffer of renal failure, that suffer of Cushing disease, that are receiving prednisone. Hey, when you go home, weigh yourself every day in the morning. Okay, so please wake up, pee first, go to the bathroom, urinate first. Don't wait for having breakfast, and weigh yourself. If you notice an increment of 1.5 pounds or around 3 pounds in 2 days, there's an increment in this amount of your weight, please tell us, tells the doctor, tells me, because it could be a manifestation that you are retaining fluids. Okay, so this is more or less the threshold of alarm. Okay, when a person is gaining weight too fast because he's retaining fluids. Another concept that you need to have clear is what is central venous pressure. You are supposed to understand the anatomy, and you need to know that a person, a normal person, okay, has a heart, a heart that needs to be working properly. Yeah. And then to this heart, you are going to have veins that brings the blood, okay, brings the blood, okay, to the heart, okay. So you have a big vein in the center of your chest called superior vena cava that is collecting the blood coming from the extremities and from the head and the neck, yes. And then doctors can introduce a catheter inside this superior vena cava. Okay, a catheter inside this superior vena cava. Usually the catheter is entering the body at the level under the clavicle, in the subclavian artery. Sorry, vein, excuse me, I have a lapsus. Vein, the subclavian vein, and the tip of the catheter is in the superior vena cava, near, not inside, but near the heart. This is called central catheter or central venous access device. Central venous access device, okay? And a nurse can measure the pressure of the blood in the tip of the catheter. So remember that blood is collecting from many parts of the body. They're in the central vein, and the amount of blood that is there in this vein is like the average of all the blood in the body, no? All the liquid in the body. So this is called central venous pressure. So a nurse can measure this central venous pressure in a very simple fashion. You know that this catheter is going to be connected to a bag of IV fluids, could be normal saline. Yeah, and you can place a ruler, a simple ruler. Okay, uh, um, the patient need to be recumbent, need to be on bed, and the ruler is going to be placed at the side of the clients in a way that the zero of the ruler is in the mid axillary line, not the anterior, not the posterior, is the middle of the armpit. Yes, the middle, okay, axillary line. The zero of the ruler need to be there, okay? And the rulers is divided in centimeters because in this field we work with the metric system. We work with centimeters. So this ruler, okay, is going to be measured in centimeters, okay? The zero is going to be in the mid axillary line, yes? And then you can feel the tubing, the tubing with normal saline or whatever liquid, yes, the tubing, and then you stop the bag. You clamp the bag and allow this column of liquid that is inside the tubing to pass toward the superior vena cava by gravity spontaneously. And then when you see that the column of liquid is stopping, okay, the column of liquid is stopping, okay, so you see that it's descending and stop. When it stops, you read how many centimeters, 1, 2, 3, 4, 5, okay, this is the central venous pressure. The column of liquid stopped. In 5, the central venous pressure of this client, imaginary client that I'm inventing, is 5 centimeters of water. Okay, is measured this way with the patient recumbent. Okay, recumbent, totally flat. A ruler divided in centimeter with the zero at the level of the mid axillary line. A tubing over the ruler, and the tubing filled with liquid. There is no more liquid coming, is clamped, the IV, and you allow the liquid to descend alone by gravity. And when the pressure in the central vein, in the superior vena cava, equalizes the pressure of the column of liquid of this in this ruler, this is read by the nurse when there is a stop in the descending column of liquid, and once this stops, the nurse reads in which centimeter stopped the liquid, the column of liquid, and this is the measurement, the lecture, the reading, the reading of the central venous pressure. Okay. Okay, so a brief review of how nurses measure central venous pressure. Doctors can measure also central venous pressure, but with a more advanced method. So instead of using a ruler, school ruler, they're using a computer that has transducers, and they use a much longer catheter. The catheter that doctors use is ending beyond the superior vena cava. So this catheter is pushed away and is trespassing the right atrium, the right ventricle, and is entering the pulmonary artery. Okay, so you know the anatomy, and then when entering the pulmonary artery, they measure several pressures: the pressure of the pulmonary artery, the pressures of the central venous pressure, etc. When the doctor measures, with the computer, the central venous pressure measures that in millimeters of mercury. So nurses measure that in centimeters of water, doctors in millimeters of mercury, doctors and specialized nurses. But when I say nurses, it's the entry-level nurse, and it is what the Nclex is going to be. Entry-level generalist nurse, not specialized nurses. For that reason, I say doctors measure a millimeter of mercury, but it includes specialized nurses that have been trained in ICU with this Schwangen's catheter and these hemodynamic measurements of pressures in the client. But we can measure that very simply, okay, with this school ruler. Okay, that's it. The only requirement is that the doctors place a central venous catheter, which is a routine, is very frequently placed. Okay, it is accepted. Yes, I think it's important to have an idea that the average normal central venous pressure in centimeters of water is 5 to 10. In centimeters of water is 5 to 10. Okay, so this is the range of normality. So if a person has, for example, 1 centimeter, it's because it has little amount of liquid in the veins. But if the person has, for example, 20 centimeter of water, because this person has too much liquid in the vein. So if you have a question that says the doctor's orders IV fluid, X fluid, at a rate of 120 milliliters per hour, okay? And also orders, okay, the measurement of the central venous pressure. After 4 hours receiving fluid, you measure the central venous pressure, and the central venous pressure is 18 centimeters of water. What means this is high? Because it's more than 10. What means this? The patient has too much liquid. And they ask what you should do. Well, the first that you should do is to stop this IV fluid, because the person is receiving is forced IV fluids in the veins and is having too much fluid in the veins. And you stop the liquid and you call the doctor. Hey, doctor, the central venous pressure is elevated, it's in 18, so I stop. Okay, I stop the IV fluids that you order, and I'm waiting for your instructions. Okay, and doctor, okay, it was too much. No more IV fluid. Okay, or let's continue, lower pace, or maybe doctors decide to administer diuretics, etc., etc. This is beyond our scope, not the individual, okay, intervention there. So this is the application of the central venous pressure. Of course, when there is fluid volume excess, the central venous pressure is elevated. So this is the pathophysiology of the fluid volume excess, okay, and is a finding in several conditions, medical surgical conditions that you need to know. So what aspects are the intervention? Well, I already mentioned the positioning. Okay, the positioning. The position is very important in nursing. Position is nursing business. Okay, the position in all the procedures. Okay, in fluid volume excess. Okay, so the position is that elevate the head of the bed as, as high as tolerated for the patient. And I explained that it's going to displace the fluids from the lungs to the lower part of the lungs, okay? And by gravity, fluids follow the gravity force. And then it's going to allow the patient to breathe much, much better, okay? You know that administration of oxygen, the oxygen is convenient in this client. I already explained that. And now you're going to participate in collaborative interventions in those patients with fluid balloon excess. So what you expect that is going to be ordered in collaboration with the physician and the dietitian, sodium restriction in the diet. Why? Because sodium is an atom that attracts water. So when you retain an atom of sodium in the kidney, when you reabsorb an atom of sodium in the kidneys, you are also reabsorbing a molecule of water. So water is a molecule that follows where the sodium is going. So now you want to decrease the amount of sodium in the body. So there is going to be a diet with sodium restriction. Also, fluids could be restricted. Have in mind that if a person has a fluid balloon excess, a part of the restriction of the sodium, also fluids could be restricted. Have that in mind. And this is nursing responsibility. So you need to be you are supposed to be knowledgeable about which food is rich in sodium and should be restricted, and instead which food is low in sodium and should be recommended. In which area nurses intervene in this process in teaching. You are supposed to teach those clients about this dietary recommendation. Um, the the sodium restriction implies avoiding practically any processed food. You need to have clear what is the concept of processed food. Any food that you are buying in a box, in a bag, okay, in a can, okay, frozen, already cooked, ready to eat, or almost ready to eat, okay, it's a processed food. A cheese, a ham, cold cuts, bread, crackers, okay, those are processed food, okay. Food that is not processed is the food that you buy raw and you cook from scratch. Yeah, this is a non-processed food. So this is an important concept. Sometimes you need to teach that to your clients, but before teaching that to your clients, you need to have the concept yourself very clear. So as I said, any kind of canned, bag, boxed, okay, food that is sold already, uh, ready or almost ready to eat, sauces, those dressings that you buy for your salads, the soups, especially the canned foods, any soup, those foods that you add water, how you call that? The food with the noodles that you add water, the ramen, okay? Uh, um, for example, incredible tomato juice have a lot of food. Okay, something that you do not have a lot of salt is milk and dairy. Milk and dairy have a lot of sodium. It's the high sodium. Okay, anything that is pickles. Okay, there are many different. It's not only cucumbers. Okay, there are many pickles. Okay, pretzels, okay, etc. Yeah, those are okay. Sodium-rich food. You need to educate yourself. By the contrary, vegetable, fruits and meats that are cooked from scratch are low sodium. And you expect also collaboratively that a person that has fluid volume excess is going to receive diuretics prescribed by the doctors. You need to know the different classes of diuretics. You know that for a strong diuretic effect, you need a loop diuretic that includes furosemide, bumetanide, torsemide. Okay, those are the three main loop diuretics. For a weaker diuretic action, you have the thiazide diuretic. Thiazide diuretic includes the hydrochlorothiazide, includes the chlortalidone, and one that have been lately in the Nclex, indapamine. Okay, indapamine. Apart the hydrochlorothiazide that you know so well. Those are the thiazide diuretics. Okay. What you need to know about both the loop diuretics and the thiazide is that they are, forcing the kidneys to pee to eliminate sodium and water. But at the same time, they force the kidneys to eliminate potassium. Potassium is a very delicate, oligoelement, electrolyte that need to be in a very precise range in the blood, 3.5 to 5. So it is a risk of developing hypokalemia, low potassium, when diuretics of the loop or hydrochlorothiazide families are used. So makes sense that unless there is contraindication, the contraindication could be chronic kidney disease, okay, or a patient that have already high potassium, or a person that is consuming other medications that retain potassium, like spironolactone. No? But apart these exceptions, the clients are supposed to have a potassium rich diet, and also a potassium supplementation. Okay, so it is an important concept. Okay, those are nursing intervention. So it is clear the concept of fluid volume excess and the interventions. Are we good? And we move to the opposite, that is fluid volume deficit. No questions. Okay. So the opposite concept is also very important, is the concept of fluid volume deficit or hypovolemia. Fluid volume deficit etiology is, well, the most dramatic, the one that we need to face as nurses in a emergency fashion usually, is bleeding. When somebody has a broken blood vessel, why? Because an ulcer in the stomach, there is bleeding. Why? Because esophageal varicose veins that are bleeding. Why? Because it has a wound, a trauma. Why? Because it has a uterus that just get rid of the placenta, the baby and the placenta, but the uterus is not contracting well, and then the wound that is left when the placenta detaches from the uterus is bleeding. When you have an ectopic pregnancy that is bleeding, when we have a patient that went for a procedure, for example, a liver biopsy, kidney biopsy, a colonoscopy, and had a biopsy, surgery. When in surgery they cut a lot of blood vessels, they need to close those blood vessels, but sometimes the blood vessels is get loose or is left bleeding, and the person after the surgery can start bleeding. No, so there is an infinite situations in which bleeding can occur in your client, and notice that all of them are absolute emergencies. And you know that a priority in nursing is to understand, that's the word, okay? Priorities. The priority in nursing is to understand priorities. Is one of the priorities in nursing. And now you understand that how important is this concept of bleeding. But also you can have a more, gradual urgencies, no emergencies, but urgencies, situations that allow, a little slower reaction, loss of fluids, as happens in people with vomits and diarrhea, okay, like people with gastroenteritis, or people with polyuria. Which one is the most common patient with polyuria? Diabetes mellitus, guys. Type 1 or type 2? Either one. because the high level of glucose in the blood translate in presence of the molecule of glucose in the urine. I mean, glucosuria, and the molecule of glucose has an osmotic capacity, can suck water, and is going to suck water from the body of the person. For that reason, the person is losing, is wasting the water of the body water in the toilet, in the urine. This is the concept of polyuria. But there are many other situations in which you can find polyuria, okay? In diabetes insipidus, in patients recovering from acute renal failure, patients that have recent kidney transplants, etc., etc., in which you can see polyuria. Patient with burns, this is a special situation in which the person is not losing visibly fluid, but there is a shift, a migration of the fluid from inside the blood vessel, where the bulimia is, to the interstitial space, to the flesh, to the burn flesh, and this is going to produce hypovolemia. That's why you need to calculate this huge amount of fluid that needs to be administered in the first 24 hours in patient with burns. Okay. There are other situations in which this kind of shift can occur, like in septicemia, intestinal obstruction, etc. That you need to know, to learn. Okay, you need to know. The extreme of the fluid volume deficit is the hypovolemic shock. Shock means that the pressure of the blood is so low that the blood is not moving. Why the blood needs to be moving? Because the heart. Why the heart is moving the blood? The reason is very simple, guys. The oxygen needed for the cells to have an aerobic metabolism to produce ATP, the oxygen is in the lungs, and the lungs are in the chest. And the oxygen of the lungs is needed all over the body. To transport this oxygen from the lung to all the cells of the body, you need the blood moving. Yes, it's true, hearts take care of that, but the heart also needs the presence of the blood. What's doing the heart is the veins and the arteries are dry. Makes sense? So this is the concept that we are mentioning here. Okay, that when there is so little amount of blood in the arteries, in the veins, you have a condition called hypovolemic shock, in which there is a dramatic drop of the pressure of the blood inside those pipes, that the blood is not moving, or practically not moving. The consequence of that is that the distal cells, are not receiving the blood with the oxygen and cannot produce ATP. And when the cells cannot produce ATP, the cells die. So there is a process of progressive death, okay, of tissues and organ, called multi-organ dysfunction syndrome. Is a domino effect, is a snowball effect, where first the kidneys, then the liver, then the lungs, then the heart, and the brain, and then the heart. The organs are dying one after the other. This is what happens with shock. Remember that when there is no oxygen in the cells try to survive. Burning the glucose, which is the normal fuel in the mitochondria, burning the glucose in absence of oxygen. This is going to produce a miserable amount of ATP, not enough to sustain life, and just to prolong, okay, the life for a few minutes. And it's going to produce a venom, a poison called lactic acid. This is what happens when we burn glucose in absence of oxygen, the anaerobic metabolism. And then you expect to have, in those patients with shock, okay, a lactic acidosis. All those questions has been in Nclex, okay? If you understand the pathophysiology of why we need oxygen, why cells start producing lactic acid when there is no oxygen, so what is anaerobic metabolism in absence of oxygen, etc. Okay, so this is what happens in the extreme situation with the hypovolemic shock. There are other causes of shocks that were studied in concept 2 in MedSearch 1. Um, but in this moment, we are centered in the hypovolemic shock. A concept that you need to have in fluid volume in general, but especially fluid volume deficit, is that you lose liquid through your urine. So each time you urinate, you are eliminating liquid, and you lose liquid if you have abnormal losses like bleeding, vomiting, diarrhea, polyuria, or shift of liquid. But then there is an amount of liquid that you lose every day normally, but cannot be measured, cannot be uh, quantified, cannot be is not visible. That are the insensible losses. Another concept that is tested in Nclex. Remember that in your breath, when you breathe out, there is a lot of water vapor in your breath. If you want to understand that, I think that they taught you that in elementary school. You only need to blow in a mirror, okay, or in a cold glass, and you see the amount of condensation of water that is produced there. So understand in your brain that a person is normally, losing water through the respiration. So now you understand if the person is breathing like you 14 times in 1 minute, okay, is losing an X amount of water, okay, of water through the breath. But if the person is breathing 28 per minute, is is losing twice this amount of water, no? So hyperventilation, polypnea, okay, tachypnea, okay, is a cause of increment of water loss through the respiration. So it is important. There are people that have very rapid respiration because they have problems of oxygenation. And the other losses that are insensible is the evaporation of the fluids or the water that is in our skin. Our skin is not dry. We are not caimans. We are not lizards. Okay, our skin is hydrated, and even our skin has the capacity of producing a visible water with its sweat. But you don't need to sweat. It's no need of sweating to lose liquid through the skin. This water is continuously evaporating, and this is part of the insensible losses. Okay, of course, you know that every person that is in a very hot environment because the AC is broken and it's summer, uh, and is exposed to the environment, to the sunlight, etc., etc. You know what I'm talking because you live in Miami. Okay, this person will have increased loss of fluid through the skin. And that's why sometimes those people arrive to the ER dehydrated. Okay. And it's something to understand. It's something to understand. This is what is the causes insensible losses. In normal conditions, okay, without being sick or without being exposed to the environment, to the hot environment, it is calculated an adult person is losing between 5 to 700 milliliters of water per day, which is a lot, and is not measured. So it is something that has been tested in Nclex, and I just wanted to refresh because I remember when I taught Ms.Edu, I insisted in that, no, and also in fundamental. But this is something that you cannot forget again. Prohibited. Okay, you cannot be forgetting more. You cannot. Now you need to remember everything for your Nclex. So this strategy that you had in the school, that I cram the information the day before the test, the week before the test, and then because I was cramming 1 week, okay, instead of cramming the 14 weeks, I'm cramming the 1 week before the test, and then I say I studied a lot. No, you didn't study a lot. You studied a lot the last week of before the test. Sorry, Sorry if you disagree. If you disagree with me, but this is not the correct. But in that test, you could afford, okay, forgetting the information once you pass the class. Okay, now you cannot forget. Okay, so it's prohibitive to forget. You need to remember. Okay, continue. So what happens when a person has a fluid volume deficit, has too little volume of liquid inside the arteries and the vein? Well, the first that the person is going to experience is hypotension. Okay, the blood pressure inside the pipes, inside the arteries is going to drop, hypotension. And who you think is going to become upset because there is a low pressure of blood arriving to its kingdom, the brain. The brain becomes very upset when there is hypotension. Brain is very demanding, guys, and demands adequate amount of blood pressure, adequate amount of oxygen, glucose, etc. One evidence that the organ that is suffering the main consequences of this hypertension is the brain, is the presence of dizziness or lightheaded when the patient is upright. When a person is upright, okay, when the person is upright. Let me make the person sitting because I need to be careful that the patient is no. The part of the body that is in highest position is the brain. And you know that the blood need to be pumped, okay, against gravity, okay, toward the brain. So it's easier to send the blood to the legs because it's in favor of the gravity force. So gravity force is going to be facilitating the movement of the arterial blood toward the feet if you are in this position. But then the highest part of the body is the brain, and is going to be the one that is going to be more difficult to send blood if the volemia and the blood pressure is low. So once the brain is in this predicament because its position in the upper part of the body is in the predicament of receiving less pressure of blood, less amount of oxygen, because the blood transports the oxygen. Never forget that, okay? So now the brain starts malfunctioning. And how you experience this malfunction of the brain, trying to think for what is the brain. Yes, for that is for thinking. Try to think for what is brain in our body is to think. Okay, so now a person is going to have confusion, for example. Yes, is going to have a deterioration of the level of consciousness. But there is a peculiarity. This deterioration of the brain function is more severe if the person is upright. If the person adopts the recumbent position, especially if you raise the legs, yes? Recumbent position and you raise the legs. This is called modified Trendelenburg, in which the person is flat, recumbent, flat, okay? Lying flat, okay? But the legs are elevated. Then what happens? Now the brain is not in the highest position. Now the brain is at the same level of the rest of the body. So now the blood arrives much better to the brain. And for that reason, the person feels much better. Much better when it's much happy, yeah? When it is in recumbent position. When the person is in upright position, the person is feeling really bad, because brain is not receiving the adequate amount of blood and oxygen. Okay, this is the explanation of these orthostatic, okay, symptoms. Orthostatic is the position upright. Upright position is orthostatic. Yes, and that's why, as we discussed in other moment, we are measuring the changes of the blood pressure when the person is recumbent and when the person is upright, precisely to detect, okay, this phenomenon that occurs when there is a fluid volume deficit. That is, the blood pressure abnormally drops when the person changes from recumbent to upright position. Remember that a drop of the systolic blood pressure of 20 millimeters of mercury. So if the person had 130 and now has 109. Okay, there is more than 20 drop of blood pressure, yeah, when the patient is upright, yes. uh if there is a drop of more than 20 millimeters of mercury in systolic blood pressure, it translates that the person has lost when there is hypovolemia around 20% of the volemia. 20% is 1/5 of your volemia. I mean the total amount of blood and liquids in your vein and arteries. So it is an early manifestation of a condition that, if not diagnosed in these early stages, when the patient has dizziness, orthostatic dizziness, and you demonstrate orthostatic hypotension, the patient has confusion, etc., in this position, then it's going to evolve to the severe, terminal, and potentially irreversible shock, because we didn't recognize this in the early, okay, manifestation. You know that in all people is especially significant this phenomenon that the malfunction of the brain produces confusion, alteration of the level of consciousness, alter mental status, and even inadequate behaviors. Okay, so be very attentive to any complaint of clients that say that they experience dizziness or lighthead when they sit up, and trying to correlate that with in which other condition is the patient that could explain a fluid volume deficit, and trying to quantify how important is this fluid volume deficit. Of course, as I said before, also in fluid volume deficit, the brain becomes upset. And okay, in the previous, the brain became upset because the lack of oxygen due to the pulmonary edema. Here, the brain comes directly upset because not enough blood pressure is irrigating the brain. And then the compensatory activation of the sympathetic nervous system will produce tachycardia. This compensation of the sympathetic nervous system also produce vasoconstriction, especially in the skin. That's why usually you see those patients pale. You recall when you develop experience, you see a person that is in a predicament, is in this balance of the homeostasis, especially is having fluid volume deficit. You recognize this paleness of this phase, this skin condition immediately. You develop this skill with experience, okay? And the person tends to be also cold because the same vasoconstriction that takes the blood from the skin. That's why the skin is pale and cold. The blood is red and warm, no? So no blood in the skin, so pale and cold, and tend to be wet, wet, moist. And this is what is called cold and clammy skin in the description, cold and clammy skin. And the person usually have a lot of thirst. It's so interesting how the person that has, bleeding, a person has these conditions of fluid immediately experience an intense thirst. It's the nature trying to compensate, okay? Because then the patient looks to recover the loss of fluid. Uh, Kidneys are going to receive a command when there is fluid volume deficit of the two hormones that we mentioned before influence the kidneys, the antidiuretic hormones and the aldosterone. When there is fluid volume deficit, when there is hypotension, the brain detects this hypotension, and brain has a structure, okay, the hypothalamus and the pituitary gland or hypophysis that can produce the do not pee hormone. So the do not urinate hormone, the antidiuretic hormone. When the brain detects that we are short of pressure, we are short of volume, we are short of liquid, the brain say, hey, kidneys, don't dare to pee because we are really short of liquid here. Okay, and this is one of the signals that immediately arrive to the kidneys, and also the renin-angiotensin aldosterone system is activated because the hypotension, the fluid volume deficit, and then the person is going, apart of producing angiotensin 2, that is also a potent vasoconstrictor, the person will have the activation of the aldosterone that tells the kidney, hey, kidneys, I am a hoarder of sodium and water for me. Don't be the sodium and water, okay? So yes, this activation of those hormones are going to produce what is called oliguria. Oliguria is when a person is peeing less than 30 milliliters, okay? Less than 30 milliliters, okay, per hour when we're talking about an adult client, okay? Or it is more or less 400 milliliters in 24 hours, okay, 24 hours, okay? And this is the oliguria that we see in those clients and can be an also early manifestation of the fluid volume deficit because it's part of the compensation. Okay, so the tachycardia, the orthostatic dizziness, orthostatic, okay, the orthostatism, as it's called, the 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 thirst, the decreased urinary output are early manifestation that occurs before the shock establishes. Why? Because those are, the manifestation of the compensatory mechanism. Yeah. While the shock is the failure of those compensatory mechanism. When the compensatory mechanism, the activation of the sympathetic nervous system, the activation of the renin-angiotensin aldosterone system, the activation of the antidiuretic hormone, yes, when all those compensatory mechanisms fail is when the patient evolves to the shock because of the failure of the nature to compensate. It depends on the magnitude of the fluid volume lost. That's it. This is something that a nurse needs to understand. Very simple. When there is fluid volume deficit, there is something called decreased skin turgor. The skin turgor can be explored making a pinch in the skin. When there is a fluid volume deficit, there is a tendency of the skin after being pinched, okay, to persist with this fold, this folding of the skin that persists for longer than normal because the loss of the elasticity, the loss of the turgor of the skin is called tenting. 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 Yeah. By the way, all people normally, without being dehydrated, have tenting, if the tenting phenomenon in the skin of the hands, the dorsal of the hands and the dorsal of the forearms. Don't explore tenting in all people in the hand. Explore that in the forehead. Explore that under the clavicle in the chest, but not in the hand because normally they have tenting. Of course, the same way that I explained that in fluid volume excess, the central venous pressure was increased. Here, the central venous pressure is decreased. But there is something interesting to discuss that is frequently in Nclex, that is how behave the hematocrit when there is fluid volume deficit related with water, no bleeding. When you are bleeding, the hematocrit doesn't alter, doesn't change because you are losing at the same time in the bleeding, you are losing at the same time the plasma and the red blood cells. Red blood cells and plasma are lost at the same time. For that reason, in acute bleeding, you don't notice changes in the hematocrit. But when there is a fluid loss, who can have fluid loss? Vomit, diarrhea, which is so important in pediatrics. Polyuria, which is so important in diabetic clients. Burns clients, okay, that are not bleeding. So is the loss of fluid not related with bleeding, okay? You are going to notice that meanwhile the person is dry, the person has fluid volume deficit, you are going to notice that the hematocrit increases. You can see here in this picture how is the normal hematocrit. The yellow is the liquid part of the blood. The red are the red blood cells. And these proportion of red blood cells, this part of the blood, the red blood cells, okay, in relation to the total is the hematocrit. So it is a little less than the half of this column, no? This column, okay? This level is a little less than a half, no? So I can say that the hematocrit in this client is like, let's see, 45%, 45%. But then this person dehydrate. So what happens with the yellow stuff, with the plasma? Decreases. So now, if it is the column, if it is the total column, this is going to be much more than a half. This is a half, no? So it's going to be like 60%. No? Do you notice how in dehydration, the hematocrit increases? Because loss of the liquid component of the blood. It's called hemoconcentration. Hmm? Hemoconcentration. Okay, but then when we administer IV fluid, normal saline, and we replace the loss of fluid, then the hematocrit, okay, drops to the previous value, to normal. Okay, so don't forget this because it's frequently in the Nclex. If hematocrit can be used as a parameter to evaluate the magnitude of fluid volume deficit when there is loss of liquids, only liquids, no bleeding. Okay, if there is bleeding, is not useful. But if it is okay, fluid volume deficit, yes, it is useful. Because your silence, I assume that I explained myself and you understood. Okay. So when you have this syndrome of fluid volume deficit, then the intervention that you expect, well, first intervention. If a person is dizzy when standing, what you do? Don't allow the person to stand. Because what happens if the person, wants to go to the bathroom, okay, walking, because it's a stubborn old person like me, because I'm going to faint, I'm going to fall, my bones are old, yes, and are brittle, and then I'm going to have a skull fracture or a hip fracture, and now it becomes something worse, okay, a diarrhea, okay, gastroenteritis becomes something worse. uh, is the nurse responsible of anticipating this situation? Yes. And it is a patient where you initiate risk for fall precautions, risk for fall precautions, and you warn the client to avoid getting out of bed. So now the client should be using the urinal or the bedpan for doing those urgencies. Makes sense, no? Or if a patient is arriving to the ER in this condition, the first that you do is to make the patient recumbent. No? Absolutely, no? Okay. Then you anticipate that this deficit of fluid should be replaced. This deficit of bulimia should be replaced. If it is only fluids because diarrhea, burns, etc., you anticipate that electrolyte, solutions. Okay, those electrolyte solutions, sodium chloride and electrolytes, are also called crystalloid. Okay, it's an old term. It's an old-fashioned term. Crystalloid, like crystalloid. Okay, IV fluids, crystalloids, electrolyte solutions, etc. Yeah, can be administered oral or intravenous. If the fluid volume deficit is mild to moderate, the oral rehydration is preferred. It is an important concept in pediatrics. In pediatrics, dehydration is common. Fluid volume deficit is common. And if it is mild to moderate and the child tolerates the oral route, okay, oral rehydration is preferred. But if the situation is severe, the person has a severe fluid volume deficit, or the person doesn't tolerate the oral, because is unconscious, is whatever. And you need to use the IV hydration. You know that you need to replace the fluids with something similar to what has been lost. And the isotonic solutions, specifically normal saline or lactated ringer, are the isotonic solutions that are used for the replacement of the fluid. So what should do a nurse when a person, for example, with severe fluid volume deficit, like somebody that is bleeding profusely, what should do the nurse immediately without waiting for doctor's order? Take two veins. Why not only one? Because what happens is vein gets infiltrated or lost. Two veins. And what kind of catheter I'm going to use? A big catheter, at least 18G, because you anticipate that this person, a part of needing IV fluids pass very fast, probably is going to need blood. And the blood preferably as administered with this gauge of catheter. And it is a common question, Nclex, okay? If you know that you need to do that first and initiate the IV fluids, the isotonics, and then once the doctor arrives, we'll tell you exactly with which speed this IV fluid is going to be passed. But you initiate that, of course, fast because the patient is having fluid volume deficit. So nurses initiate this intervention and is going to be supported by the providers, the prescribers. Okay, those are the interventions. Is okay? The nurse is reviewing the lab results of a client admitted 6 hours before because dehydration and has been receiving oral IV and IV hydration. Which of the following parameters is indicative of a normal hydration status? Platelet count, 180,000. BUN, 26 milligrams per deciliter. Hemoglobin, 17.6. Okay, if I have this hemoglobin 17.6, you say, okay, but hematocrit is the one, okay. So how much hematocrit is hemoglobin? 17.6. So let's see, multiply times 3. So 3 times 6, 18. I take 1. 3 times 7 is 21 plus 1 is 2. Uh, I carry 2. 3, 1, 3 plus 2 is 50. So the hematocrit is 52, okay, almost 53%, okay. This hemoglobin is a hematocrit 53%. If you were not paying attention, you need to know how those numbers appear. If you multiply the hemoglobin times 3, you get the hematocrit. And this patient has hematocrit 41. Okay, so platelets is not used for that. BUN has a parallel behavior with hematocrit in dehydration. BUN increases in dehydration. So a BUN, the BUN, normal BUN is 10 to 20. In 26 means that the patient is dehydrated. Yes. A hematocrit of 53, where is this 53? It came from multiplying this hemoglobin times 3. A hematocrit of 53, okay, means that the patient is dehydrated. But this hematocrit is normal. Which hemoglobin is this hematocrit? So divide 41 by 3, okay, by 3. So it is going to be 13 point something hemoglobin, yeah? So this hematocrit is normal. So obviously, the normal hematocrit is the parameter of these 4 that tells the nurse that the person has already a normal hydration status. It is an example how can be tested that. You need to know that the IV fluids are classified mainly in isotonic, hypotonic, and hypertonic. This is the most important to know for test purposes. If you weigh in a balance 0.9 grams of sodium chloride, table salt, Morton salt, yeah, and you dissolve this amount of sodium chloride in 100 milliliters of water, you have a solution 0.9%. This solution is very similar to the composition of the plasma in relation with sodium chloride and water. And for that reason, it's said, oh, it's isotonic, isotonic. So it has a similar tonicity or concentration in relation with the normal plasma. And you know that because it's isotonic, we call this a normal solution or normal saline because it's made with salt, normal saline. So that's why it's called normal saline because it's isotonic, okay, and is saline because it's made with sodium chloride, yeah, and that's why it's called also 0.9%. Yeah, very good. If this same solution you add, okay, some stuff, you add a little potassium, you add a little calcium, you add a little lactate to balance the acidity of the solution, then you have a normal saline called lactated ringer. It's a more balanced forms of isotonic fluid, but at the end, there is no big difference. It's normal saline and lactated ringer is practically the same. Both are isotonic, but the lactated ringer has a little potassium, a little lactate. So in which patient is preferred the lactated ringer over the normal saline? In burns clients, okay, burns client. In which patient you don't want normal lactated ringer, patient with high potassium. If you have a person who have high potassium, okay, or high lactic acid, you don't want to use lactated ringer. You prefer to use normal saline. Nclex question. So which client is the one that more frequently you see with high potassium because you are graduated from the School of Nursing, no? Renal failure. You need to know that because you are graduated from the nursing school. Renal failure. Patients with renal failure have high potassium. But there are many other clients that could have high potassium. Yes. You know that high potassium produces in the EKG an T wave that is tall and peak. So this is the way that could be presented in your Nclex. Is a client, which of the following clients have contraindication of using lactated ringer? A client that have on the EKG a tall and peak, tall and peaked, okay? Okay. Um, T wave. Because it's a manifestation of hyperkalemia. No? So in that client, you don't want to administer potassium IV. Okay, same as patient with high lactic acid in the blood. Okay, a patient with shock, etc. It's not convenient to use the lactated ringer. So this is the secret of the lactated ringer, no? And when to use, when not to use. Okay, and those are the solutions more frequently used. Okay, the isotonic, and are used to replace volume. Okay, to replace volume. Sometimes the factories offer a more diluted solution. So instead of weighing 0.9, which is the same as 0.90, you weigh only 0.45 grams. Okay? Why? Because it's the half of 90, 45 is half 90. And then you dissolve this. This is the same sodium chloride. This is also a saline solution. It's a half saline, half normal saline. And you dissolve these in 100 milliliters of water. Yeah, you have a solution 0.45%. This is a half normal saline. And it is hypotonic because it's more diluted, no? Has less sodium, more diluted than the normal plasma. So when doctors prefer to use this hypotonic solution when they don't want to administer too much sodium, not too much sodium, so they want to restrict and to decrease the amount of sodium, and they want to administer more water. Why? Because this solution have less sodium and more water, and that's why it's hypotonic. It's more watery, it's more diluted. So in situations, for example, when the sodium is high, you have a person that needs hydration, needs liquid, IV liquid, but the sodium is high. The sodium is 150. So which solution you anticipate the doctor will choose? A hypotonic solution that have less sodium and more water. It's very simple. Don't complicate. So which client, for example, could require a hypotonic solution? A patient with diabetes insipidus, disease that you should know from the school, in which there is a dehydration, but there is a hypertonic dehydration. The patient has very high sodium. It is an example. And it's an Nclex question. Which type of IV solution you anticipate doctors will order in a patient with diabetes insipidus, severely dehydrated? And the answer is hypotonic or half normal saline. This is the Nclex, guys. If the factory that makes this solution wants to offer other alternative, then the factory is weighing, instead of weighing the 0.9 grams of the normal saline, is weighing 3 grams, 3 times this practically. And it's going to dissolve this in the same 100 milliliter of water. This is sodium chloride. So now you have a solution 3%. And this is hypertonic. This solution has a lot of sodium in little water. So if, for example, you have a client that has a very low sodium, okay, especially those clients that have critical hyponatremia, that is when you have a sodium in less than 120 milliequivalents per liter. You know, the normal is 135, no, but 120 is very low. Brain is at risk of having permanent damage with this level of hyponatremia. Then doctors could want to use, okay, a hypertonic saline solution, 3%, to correct the hyponatremia. This kind of solution, because are so salty, when administered in being in the pipe, in the vein, this kind of very concentrated solution has the capacity of sucking water, okay, pull water from the flesh, even from the cells. So you can transfer water that is in excess in the flesh, in the cells. You can transfer this water from the flesh to the IV circulation, And you know that this IV circulation is going to bring this water that was in the flesh is now going to be taken to the kidneys, by the circulation, and kidneys can then pee in the toilet, okay, this excess of water. This is especially important when you have brain edema, which is a very serious condition. And you can use, okay, this hypertonic solution to suck water from the brain, okay, from the flesh of the brain, take this water to the circulation and then to the kidney to be impeded. This is also done by a diuretic called mannitol. Okay, this is the other that can do the same, mannitol. Okay, so for brain edema, doctors can choose either mannitol or hypertonic solution. Okay, so they decide that depending on the preferences of the case. Okay, okay, so this is the applications. Okay, of the hypertonic solution. The other solution has dextrose. Dextrose is the same as glucose. So you see, dextrose is the same as glucose. It's the same person with two names or nickname. And you know that when you have a dextrose or glucose solution, you can have, for example, a D dextrose, 5 grams in water, 100 milliliters. It is 5% glucose, or can be D10W or D20W, etc. 10%, 20%. So the glucose, for what is glucose? Okay, glucose in the body, once it enters in the vein, is immediately cut. The glucose, the molecular glucose in the vein, is not going to last too long in the vein because immediately is going to the cells. Cells eat glucose. Insulin pushes the glucose inside the cells, and inside the cell there is an oven called mitochondria that is continuously burning glucose. And when the molecule of glucose, this molecule of glucose that is going with the dextrose solution, okay, with the 5W, for example, enters the mitochondria, the molecule is destroyed, is burned, releasing ATP, releasing heat, because also heat is released as energy, and releasing water, and releasing carbon dioxide. The carbon dioxide, you breathe out the carbon dioxide. You are supposed to know that you breathe out the carbon dioxide that you are continuously producing in all the cells of your organism. The water, well, the water, you pee the water. Okay, you do whatever you want with this water. The heat, yes, you are hot. Okay, or you are hot. Okay, the day that I die, I'll be cold. Okay, and the ATP is used for multiple functions. This is something basic in the metabolism, and you know that this burning of the glucose must be in presence of oxygen, is aerobic, and this is something basic. But then when a IV fluid is made with glucose, then the factory takes glucose or dextrose and add this to the water. So now when you have, for example, 5%, the osmolarity in the bag of IV fluid, okay, in the bag, in the box, okay, in this moment, the concentration is similar to the plasma, is isotonic. But once this enters in the blood, the water continues being water, but the glucose is immediately transported in what? In water, CO2. That doesn't count because you breathe out. ATP, it doesn't count because it doesn't participate in the cell. So summarizing, dextrose solutions are water with water. So they are at the end hypotonics. All them are hypotonics. That's why you can't administer fluids hydration exclusively with D5W in a person that is MPO. Why? Because they are giving water, and the patient is going to become a bubble of water. Okay, you need to give sodium. Understand? In the IV hydration. So when is administered the dextrose or glucose solution? Well, when you want to administer glucose. Why I want to administer glucose? Two reasons for that. One, the patient is hypoglycemic. You know also the concept of hypoglycemia, and you can, correct the hypoglycemia administering dextrose solution. Can be 10, can be 20, can be 50 or more. But the other reason is when you want to supply calories, when you want to supply ATP. So sometimes people cannot eat, cannot eat. Okay, so it's NPO and it's NPO for a long time. So need to obtain the calories, okay, need to obtain the ATP from somewhere. And then you administer, okay, dextrose in abundance, very concentrated dextrose solutions, okay, uh, to provide ATP, to provide calories, and it's part of the total parental nutrition. Yeah. So those are the main reasons to administer dextrose solution, to manage hypoglycemia, to prevent hypoglycemia, and to administer calories, to administer, the source of the ATP for the cells of the body in the form of TPN. But you know that a part of this supply of dextrose, you need to give also sodium chloride and potassium and calcium, etc., because it's needed. Okay, very good. So those are the interpretation of the IV fluids that a nurse need to have very clear, and can be tested in many ways in the Nclex. No questions. Okay. Peripheral venous access devices. Okay, this is something that we nurses can do, and these are the catheters they can insert. We are allowed to insert that. It's important that we insert this in adults. Remember, the Nclex is mainly adult, nursing. We insert that in the upper extremities. We don't use the lower extremity because we can produce a thrombophlebitis, even a deep vein thrombosis. In children could be used. Even the veins of the scalp can be used. But as I said, Nclex is entry-level generalist nursing, no specialist pediatrician nurses. And that's why you need to follow better my guidance in adulthood. You need to know the anatomy of the arm, because first you need that to decide and to document in which place you inserted the catheter, and second, because it's tested in Nclex. So you need to know that this part of the body, the upper extremity, is called arm, and this part is called forearm. Okay, we try to avoid the dorsal veins of the hand because are very painful, very limiting. Okay, this is the dorsal. We try to avoid this. In good nursing, we don't use those veins. It's extremely painful. Okay, your hands need to identify everything, even if you are blind. In your brain, you have a very huge representation of your hands. So it means the hands have a lot of pain receptors and any kind of receptors. So common nursing, okay, try to avoid those pains. I know what you're saying, but I know that, but it's better to work with those pains, okay, are much less painful, are going to last longer. The hands are moving a lot, and if you have a catheter in your dominant hands, you don't even can scratch if you're having itching. So trying to understand that. But apart, the anatomy is mainly to know the name of the veins. Okay? So notice that there are two main veins. Okay, one is lateral, okay, in the radial part, and one is medial. No, okay. The lateral is called cephalic vein. All this vein is called the cephalic vein. Cephalic vein. Yeah. And the medial is called basilic vein. So those are the most important veins. Okay, so the cephalic and the basilic. Okay, so if you at least remember this, you are gaining a lot. Nevertheless, in the middle, between these two veins in the middle of the forearm, you have another vein called the median vein of the forearm, okay, that forms a Y connection with the cephalic and the basilic here that is frequently used. This Y connection is frequently used to draw blood or to introduce PICC lines, okay, in the clients. And this is called the median cubital, okay, the median cubital vein, this Y connection, and the cephalic intermediate vein, okay? But at least, please, being able to recognize which one is the cephalic, the one that is in the thumb in the radial area, and which one is the basilic, okay? That is the medial one. When you insert a catheter, you insert a catheter in the branches of those main veins, and you need to document, okay, a catheter inserted in the branch of the cephalic vein of the forearm of the right upper extremities. This is the way of the catheter number 18 inserted in a branch of the cephalic vein of the forearm of right upper extremity. This is the correct documentation of a nurse that knows what is doing. Okay. It's important that for this procedure, you should avoid extremity that have AV fistula, people with dialysis, lymphedema, ladies with mastectomy, of course, any kind of infection, yeah, and should also be avoided a person with a stroke and paralyzed extremity, because the lack of movement favors the thrombophlebitis. If it is possible to avoid the dominant extremity, it's much better because it's like a restraint of the movement of the person. If it is not possible, well, cannot be. Okay, so an important detail. The steps of the insertion and the removing are frequently tested. How? Well, mainly put in order, okay, the steps to insert or to remove a peripheral venous access device. So remember that they call that in English peripheral venous access device. Why they call it peripheral? Because those veins are peripheral veins, in contrast with the vein here that are central veins. Okay. Uh, After you get the order for insertion, verify the order, and you inform the client what you're going to do. You wash your hands and don't clean gloves. There is not necessity of wearing sterile gloves, okay, to insert a peripheral venous access device. Nevertheless, the procedure is sterile. Why there is not is not mandatory to use sterile gloves? Because you are done in clean gloves, you clean the skin with the antiseptic, and you allow the antiseptic to dry, and you cannot, it's important, here is the question, you cannot touch the skin after you clean, because your gloves are not sterile, and if you touch the skin, okay, then you are contaminating the site. But at the same time, if your gloves were sterile, you contaminate your gloves. So that's why the procedure can be done with clean gloves, but once you clean the skin, you cannot touch again the skin. So you need to decide which vein you are going to pierce, you are going to access before cleaning the skin. Once you determine the vein that you want, is you clean the skin, okay? And you don't touch again. And when you hold the equipment, I mean the catheter that is going to be introduced, you hold this in the base. You never touch the portion of the catheter that is sterile, covered by the protection that you remove. This portion of the catheter is never touched by you with the clean globes. And that's why this portion that is the one that need to be stay sterile is kept sterile, even if you are wearing clean gloves, because you never touch this. That's the rationale of why you can use clean gloves. So you place the tourniquet. You place the tourniquet 3 to 5 inches proximal to the insertion site. It has been tested. You need to know that you have the extremity. This is a green person. Okay. If you want to access at this level, then you place the tourniquet proximal. Okay. Proximal. This is proximal. This is distal. Yes. 3 to 5 inches. Okay. Okay. Proximal to the insertion site. Yeah. Proximal. Yeah. And you clean. Allowed to dry. Then you are going to do a detox with the non-dominant hand, because the dominant hand is hold your dominant hand. Let me make the nurse okay red. The dominant hand, your dominant hand is holding the catheter, is holding the IV needle and the catheter. Yes, the non-dominant hand is is the non-dominant hand is here, making taut the skin, so the vein is anchored, is not moving. Okay, full skin taut to anchor the vein, and then you insert the needle in the vein. When you insert the needle, you see blood coming through the shaft, through the back, blood coming there, and then you know that you slide the plastic part, the soft part that is covering the needle inside the vein. You activate the safety mechanism to retract the needle and avoid accidents, okay? Punctures, accidental punctures. And and uh, and you make pressure here while connecting the IV fluid, okay? And you apply over the catheter a transparent dressing, and you put your initials and the date, and you document. Before doing that, guys, please find a pad and put that, if the patient is in his bed, so you don't mess with the linen of the clients, because usually there are some drops and it's very inadequate, leaving the linen stain with blood. Remember, those sharps need to be discarded in sharp containers. Okay, and that's the procedure to insert. How is going to be tested? Well, they are going to be tested in different ways. Now, first, if you understand all those steps, okay, what means each one of those steps, why you don't touch again, what the following the nurse is doing when inserting a catheter that the nurse supervisor need to intervene. The nurse touches again the vein after cleaning the skin, for example. No? The nurse places the tourniquet distal to the insertion site. So put that in the hands and they are inserting that in the forearm. Okay, this kind of stuff. No, the nurse forgets to activate the safety device to hide the needle, the stylet. Okay, etc., etc. The nurse should apply transparent dressing because allow you to see the condition of the skin in the insertion site to diagnose phlebitis or to diagnose infiltrations, etc. Removing the peripheral venous action device. Okay, you check the order for the removal. You got the hand done, clean gloves. You clamp the IV infusion, and you remove the dressing, this transparent dressing. Yes, you place a gauze over the catheter and the IV side, making pressure to prevent the blood from coming out when you remove the catheter, and you pull the catheter. Don't forget to check the catheter to be sure that it's complete, because there is a very remote possibility that a fragment of the catheter can be detached and then produces a cat embolism. If you, for example, you know that I think that you know how those catheters are. Those are a a, a metal, okay, steel, okay, stylet, okay, or needle, and over it there is a plastic. No, este color no me gusta. A plastic, okay, a plastic, okay, uh, catheter, no? So once you get the veins and you see the blood, okay, the blood, because you enter the vein, the blood coming here, you slide the plastic inside the vein, no? Inside the vein, because it's atraumatic. But if you try to return back, this catheter, okay, having the needle or still in the vein, then you can cut the catheter. If the catheter was, advanced, and then you see that something's wrong, and then you pull back the catheter over the needle can cut a piece of the catheter. This is what happens when there is and then you make pressure there to make it coagulate and cover with a band-aid or transparent dress. Again, how is going to be tested is going to be tested placed in order the steps to remove a peripheral venous access device, and then they give you those steps in this order, which is a logical sequence, and then you put that in a logical sequence. The central veins access device has different types, okay? The main two types are the peripherally, you know what is peripheral, no? This is peripheral, this is central, yes? Okay, so peripherally inserted. What means insertion? How enters, where enters the catheter. So peripherally inserted central catheter. Why central catheter? Because it's a very long catheter that is advanced once inserted here in the arm. Yeah, inserted here in the arm is advanced until the tip of the catheter is in the superior vena cava, near, not inside, but near the heart. So it's a central catheter, but peripherally inserted. When you insert this catheter, there is some catheter left outside. Because you measure, okay, how much catheter is going to enter. This is done by the doctor or is done by a specialist nurses. Okay, so is the procedure of insertion is not the question that you would have in your Nclex, but at least you need to understand that enters in the arm, but the tip is in the superior vena cava. This is a PICC line, peripheral inserted catheter. Some of the catheter is left outside the skin. This amount of catheter outside must be measured by the person who inserts the catheter and should be documented, because each time you go to administer medication, you need to measure this segment that is out of the skin. So suppose that I inserted the catheter and I left 10 centimeters out of the skin, because it was for the size of the patient, was the amount of catheter that enters. I make my x-ray, that always you need an x-ray to verify that the tip of the catheter is in the superior vena cava. Yeah. And I made my x-ray, the catheter is okay, I had 10 centimeters. But then 5 days later, when I go to administer the medication, I measure this, and I found 18 centimeters. What means that? For any reason, the catheters have been pulled out, okay, 8 centimeters. So now the tip is not anymore in the superior vena cava. near the heart, as should be. Okay, so now that's the rationale why you need to measure and document this distance. This kind of catheter allows the administration of any kind of medication that must be administered in a central vein. Like, for example, the parenteral nutrition. The parenteral nutrition requires being administered in a central vein because the fluid that is administered is too thick, is too hyperosmolar. And if administered in a, I'm sorry, if administered in a peripheral vein, would burn and coagulate this vein. Why it is not happening in a central vein? Because the flow of blood in the central vein is huge. 3 to 5 liters, 3 to 5,000 milliliters of blood circulates in the superior vena cava each minute. Each minute, 3 to 5 liters pass, flow in the superior vena cava. So each drop of the thick fluid that is dripping there in the tip of the catheter is immediately diluted by this high flow of blood that happens in the superior vena cava. So very burning, irritating substances like vancomycin, like potassium chloride, like calcium gluconate, like total parenteral nutrition fluid are better administered through this central vein. This kind of peripheral inserted central catheter are safe enough as to send the client home with the catheter. And a IB nurse or a nurse can go home. A home health nurse is that the answer, is the term. The home health, nurse can go home and administer the medication without the patient need to be hospitalized. Um, the There is a low risk of important infection because if there is an infection, the infection starts here in the skin, in the site of insertion, but this site is too far from the general circulation here. So is diagnosed early and the catheter will be removed. So that's why it has less risk of infection than a central directly inserted catheter. And there is less risk of air embolism because the length of the catheter prevents massive inhalation of air in case of being disconnected. Those catheters don't need to be uh, connected to a hanging IV solution. You can have in the tip um, a valve that is called sailing lock. Okay, sailing lock. Sailing lock. Okay. In the past, it was called heparin lock, but it's not called heparin lock anymore. It's a valve, it's a device, cylindrical generally, that is attached to the female of the catheter, okay, and has a valve inside that after flushing the catheter, the valve prevents the liquid from coming out and blood from filling the interior of the catheter. Um, okay, so those are the most important aspects of the peripheral um, insertal central catheter. The central catheter without peripheral is directly inserted by the physician through generally the subclavian vein, less frequently through the internal jugular vein, but this is has a problem of more frequent infections, so that's why it is preferred. So the doctors are going to insert this. Doctors are going to request you to your help. So you are going to place the client, okay, in Trendelenburg position or modified Trendelenburg. So it means the patient needs to be flat, but the legs should be elevated with pillows or whatever. Yes. The idea of having the patient in this position is that the blood the blood is moving, okay, because the position to this area, you understand? Because it's moving in this direction. And the subclavian vein is going to be distended enough by blood as to be easily taken, pierced by the physician inserting the catheter. The face of the client could be, the doctor will tell you. I was reading that most doctors prefer to leave the head straight, not turn to the other side. But in nursing, we still learn or study that the head should be turned to the other side to prevent the breath of the client contaminating the area. Doctors prefer, with what I read, leaving the head neutral, o sea, neutral, not turned, but placing a face mask over the nose and the mouth of the client. Why doctors prefer? Because doctors are the one who insert the catheter. So the head is going to be placed as the doctor requests, because it's the doctor the one that is going to insert the catheter. They say in their rationale, when the doctors are allowed to speak, okay, that they prefer the head neutral, not turned to the other side, because it produces distortion of the anatomy of the subclavian area when they turn the head, and make more difficult to get the vein. So that's the rationale. I'm just sharing to you, but you can have in a test turning the head. Okay, it is okay. If the doctor doesn't agree, we'll ask you, okay, return the head to neutral position. You can place a face mask in the patient and the Trendelenburg position, okay? And it's going to facilitate the insertion. After the insertion, you don't need to keep this position. You return the patient to the semi-Fowler comfortable position. Always after the procedure of insertion of a central catheter, a X-ray need to be done. In this case, for two reasons. Do you remember that I said that the reason for the X-ray after the PICC line was to verify that the tip of the catheter is in the superior vena cava? Yes? Okay. Here, one reason is the same. Verify that the tip of the catheter inserted by the doctor is in the superior vena cava. But the other reason, that because they are using a needle in this area where the right lung in this case is, there is a remote but possible risk of pneumothorax. So an X-ray should be done to verify that no pneumothorax has been produced by the insertion. So there are two reasons for the X-ray. Recent Nclex question. If you know the reason, what you can see, why is this done, the X-rays, okay? Nurses need to know all these whys, okay? The rationales of this, okay? Very good. So this is the central venous access device. This, of course, is a little more delicate, because notice how short is the distance between the site of the insertion, where the skin is broken, and there is a possibility of penetration of infection, and the heart. So if this area becomes infected by the natural flora of the skin of the client, soon this infection can reach the general circulation, and now your patient is going to have a general infections in blood. So those are the catheter-related, okay, sepsis infections, no, that are very severe and very feared. There are variations to those central catheter. Sometimes doctors do what is called a tunnel. You know what is a tunnel, no? In Miami, we have a tunnel in the port, okay? A tunnel catheter. So as you know, the catheter is inserted here in the subclavian vein, yes? So the catheter is inserted here. But the catheter, once is inserted, where am I here? Vamos a ver si blanco se ve mejor. Okay. Once it's inserted here, the catheter is brought under the skin to a distant, okay, side of exiting. So the purpose of this procedure, the creation of this tunnel in the subcutaneous, is first a part of giving stability to the catheter, is making more difficult to any infection that could occur here in the site of insertion, reach the vein and then reach the central vein. You understand? So this is a tunnel catheter. So less risk of infection if it is a tunnel catheter compared with the catheter left entering directly over the subclavian vein, And the other option that has probably the lowest risk for infection is a port. This is a variety called ported ACAD, okay? In that case, the doctors insert the catheter as these in the vein and push the tip until the superior vena cava, but then make a tunnel under the skin, a tunnel similar to this. You can see here the tunnel under the skin, and place at the end of the tunnel a device called a port that is going to be under the skin. So here the client had a wound with stitches that is already healed. Here also has a wound with stitches to enter the catheter subcutaneous, yes, like this. No, here they discover a wound with stitches to make you understand. No, it's not going to be, those details are not going to be included in the Nclex. But recognize, because it's Nclex question, recognize that now this catheter has a minimum risk of infection because the axis of the catheter is under the skin. There is no wound, there is not a skin breakdown, there is no portal of entry for the infection. When a medication must be administered, this port is administered by a nurse with extreme sterility. Okay, so face mask for everybody, uh, a sterile gloves, a special needle, yeah, and that's why it is less possible. Okay. So summarizing, the most feared, okay, complication of the central catheter is the infection. So any sign of infection that you notice in the skin, in the site of insertion, should be reported as soon as possible. It is a common Nclex question. It's the priority. Is the first patient to see, the priority to report, etc., etc. When you have a catheter, either peripheral venous access device, okay, or a central catheter, before and after administration of medication, blood, etc., you need to flush the catheter with normal saline. But you need to know, you must know, you must use a syringe. Well, the amount, let me cover that first. The amount of fluid that you are going to be administered is very small, generally twice the capacity of the catheter. And generally it is around 2 to 3 milliliters. So with 2 to 3 milliliters of normal saline is the amount usually ordered to flush a catheter, any catheter. But this amount of normal saline need to be passed with a syringe of 10 milliliter or higher. You cannot use a syringe of 5 milliliter to pass these 2 milliliters. You cannot use a syringe of 3 milliliters to pass these 3 milliliters. You must use a syringe 10 milliliter or higher. The rationale for that is that the pressure generated for a small diameter barrels, like the 3 milliliters or 5 milliliters, is much more higher than the pressure generated by a 10 milliliters or bigger. The very high pressure generated by smaller syringes can break the catheter. The other possibility is that the catheter should be in the superior vena cava, can become dislodged. So what you can notice, what I said before, you can notice that the catheter is much out, longer outside than before. That's the rationale for always documenting the amount of catheter that is left outside the skin. Okay, that's the rationale to document this amount of catheter left outside the skin. But the other that you can, notice is that when you are going to flush, when there is dislodgement, what is dislodgement? The catheter should be inside the vein, no? This is the vein. Inside should be the catheter, no? Sorry, it's not obeying me. The catheter should be inside, no? So now the catheter is outside. Yeah, it's dislodgement, yeah, of the catheter. So when you flush, the patient is experiencing pain. So it's important to know, because maybe you don't know that when a person has a catheter in the superior vena cava, there are not pain receptors in the superior vena cava. So when you flush, and the catheter is okay in the superior vena cava, the patient doesn't feel anything. But outside the superior vena cava, in the flesh outside, okay, you have pain receptor. If the catheter is outside the superior vena cava because dislodgement, and you flush, and the liquid is spilled in the flesh outside the superior vena cava, is going to stimulate the pain receptor, and the patient is experiencing pain. Summarizing, pain is unacceptable when flushing those catheters. Period. Simple. Don't complicate. The other possibility is obstruction. Notice you have here a picture that sometimes the catheter has 2 catheters in one, even 3 catheters in one. It's called bilumen or trilumen. So yes, it's 2 in 1. So you have 2 different catheters together, okay, inserted there. There are 2 different lumens in the same catheter. Okay, and sometimes you flush one of them and you find resistance. Please don't force, because more probably is a clot. Nevertheless, sometimes it's not a clot. So they're going to ask you, what you do if you notice resistance when flushing one catheter. Okay, what you do is ask the client to raise the arm, and cough. Sometimes the catheter is pinched between the rib and the subclavian bone, or maybe the tip of the catheter is touching the wall of the vein, and with this maneuver, raising the shoulder, raising the arm, and coughing, this is corrected. And then you notice that the resistance disappears. It is an Nclex question. What you do first? If the resistance persists after this maneuver, then it is a clot. So what you need to do is label this catheter as do not use and report to the doctor. The other lumen, if it is patent, is not offering resistance, can be used. The doctors can use thrombolytic medication to disobstruct clot catheter if they consider necessary, instead of replacing the catheter. Okay, thrombolytic, are those substances of the family of the TPA, tissue plasmin activator, TPA. The prototype is the alteplase, that can be used to dissolve clots in the coronary arteries in patients with acute myocardial infarction, or to dissolve the clots in the brain arteries in the acute thrombotic stroke, but also can be used to dissolve clots that are formed inside catheters and fistulas, etc. There is a risk when you know that those catheters, this blue and red stuff that you see here is the saline lock. But sometimes when the catheter, let me use the other one. When the catheter is connected with a tubing, as you see the tubing, okay, that goes to the back of IV fluid, okay, there is a risk of disconnection. So the tubing can accidentally be disconnected, and now the catheter is left open to the air. So air can enter here in the heart. Air can enter here in the heart. Each time the patient breathes in, so the air is entering to the right atrium, is passing to the right ventricle, and from the right ventricle can pass to the pulmonary artery. And a bubble of air in a small branch of the pulmonary artery can behave the same as a thrombus, is obstructive, is a physics of the fluids when traveling through a tube, through a pipe. So this is called air embolism and is behaving similar to the thromboembolism when it's coming from a deep vein thrombosis. So the patient, once is having this air embolization, is going to acutely, suddenly experience distress, hypotension, respiratory distress, so shortness of breath, because there is no good gas exchange there because the obstruction of the blood flow, and the patient becomes critically ill. When you enter the room, of course, it's the room of a patient with a central catheter that was receiving maybe total parenteral nutrition, okay? And when the nurse enters, finds the catheter disconnected, probably the bed is soaked with the IV fluid because it's dripping outside the catheter, and the patient in distress. And this is the clinical presentation of an air embolism. The prevention when you attach the tubing to the central catheter is to make a very tight and well secured attachment. And when you need to change, because usually you need to change every certain time, you need to change the tubing and the bag. You need to change the tubing and the bag. Don't forget to ask the client to do Valsalva, to bear down, to prevent the client from breathing in through inhaling, through breathing in. If the client is unconscious and cannot follow those recommendations, then you can place the clients in Trendelenburg or modified Trendelenburg to increase the pressure of the blood in the superior vena cava, preventing the air from entering, opposing the entrance of air. That's the intervention to prevent the air embolism. If the air embolism does already occur, already happens, okay? So you see the scenario of a patient that has a central catheter and then is calling you because it's in distress, and you find the catheter disconnected and you suspect an air embolism. So when it happens, you are going to place the clients in a very weird position. It's called left lateral and Trendelenburg. I try to draw that there. So the patient is in lateral position. It's not supine, it's not prone, it's in lateral position, but specifically left lateral, okay? Specifically left lateral. Left lateral, okay, position. And eh, um the 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 this is the position. The purpose of this position is to bring the bubble of air trap in the right atrium and prevent them from moving to the pulmonary circulation. Okay, this is the rationale of doing this position. Of course, the first that you are going to do is to clamp the tubing so no more air is entering when the patient breathes in, to put the patient in the left lateral and Trendelenburg position. That means the oxygen and call the rapid response team. Once the doctors inserts the central catheter, you are going to take care of this central catheter periodically. The each facility have a schedule of changing the dressing of the central catheter. But in general, what you need to know as this change is done not frequent, because if the dressing is in good condition, there is no need of changing it. Manipulation, excessive manipulation in frequent changes of the dressing can increase the risk of infection and contamination. So the reason for definitively making a dressing change will be that the dressing is loose, because it's like a sticker, transparent sticker that need to be very well attached, sealing, okay, the insertion site, or is soiled, is soiled, yeah. But there is a schedule of changes that will be specific for each facility and depending on the type of central catheter and the type of client. So the important is not how frequent, after how many days it changes. The important is when to change and to follow the facility policy. The steps to change the dressing of the client is gather your equipment, explain to the client, hand hygiene, wear facial mask, you and the client. And first, it is important, you are going to don non-sterile clean gloves to remove the old dressing. Remember that you had an old dressing that had been there for several days. Outside, this dressing has a flora, is contaminated. So you are going to remove this old dressing for standard precaution with gloves, but needs to be clean gloves. Once you remove the dressing, you don't touch, but you assess visually the insertion site. And now you proceed to do the cleaning of the area. You don't sterile gloves that comes in the equipment for the dressing change. And with chlorhexidine, you are going to scrub energically the insertion site at least for half a minute and allow it to dry the chlorhexidine. Remember that the antiseptics, including alcohol, kills bacteria in the moment that they dry. If they are still wet, they are not yet, the bacteria are not yet killed. Bacteria die by dehydration when the antiseptic dries. A part of doing the scrub of the skin around the catheter, you need to clean the catheter in one motion from insertion to distal end. Never the opposite. It was a question in the Nclex. What we're doing around the nerves. So remember, if you have the client, you have the client. Okay, this now is a blue client. This is a blue client. Okay. Um, and then if you have the catheter inserted here, you are going to be cleaning okay, from insertion site away, never the opposite. You are not going to sweep the bacteria toward the insertion site. You are going to sweep to clean to 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 clean, okay, to wipe from insertion site away, okay. And the nurse was doing the opposite, was cleaning from distal to proximal. This is the classical question when the charge nurse need to intervene. Okay, a new nurse is doing a dressing change, and then the nurse supervisor is observing the new nurse doing that when the supervisor need to intervene. Okay, uh, we don't use antibiotic ointments. Maybe it could be a trap. In the past, it was used, but now it's not recommended because it has been associated with candidiasis, candida sepsis. So no antibiotic ointment. Nevertheless, in dialysis catheter, which is another story, this is not dialysis, this is another story, those antibiotic ointments could be indicated. You know that it is based in evidence, in research. Apply transparent dressing over the catheter daytime, initial, and document. So those are the steps. How is frequently tested? Give you the steps and you put that in order. Possible complications, infiltration of the IV fluids, or thrombophlebitis. So what is an infiltration of IV fluids? The catheter that should be inside the vein get dislodged, now is outside the vein, and the IV fluids, instead of being delivered inside the circulation, is delivered in the flesh, in the tip of the catheter that is in the flesh outside the vein. And then the fluids accumulate locally. Because those fluids are hanging there in the AC of the room, usually this swelling is cold, and the intervention to stop the IV fluids, remove the catheter, and elevate the extremity. Elevate the extremity. Sometimes the catheter is inside the vein. It's not dislodged, it's inside the vein. But the own presence of the catheter or the liquid that is flowing from the catheter, through the catheter, produces an inflammation, a burning of the endothelium of the vein. So now you see all the tract of the vein with signs of inflammation. Signs of inflammation is redness, warmth, pain, okay, and swelling. So, but you see that only in the tract of the vein. So you see the streak, the red streak, that is the vein. Usually it forms a clot, it's a superficial thrombophlebitis. And this superficial thrombophlebitis has low risk of pulmonary embolism. It's different from the deep, no superficial, deep vein thrombosis. The intervention here is to stop the infusion, remove the catheter, and elevate the extremities and use warm compresses. Sometimes you have something more serious that is called extravasation, of when the substance that is extravasation is not IV fluid, is a vesicle. So we usually in nursing reserve the term infiltration when there is an IV fluid, which is not harmful for the flesh. It's not going to produce necrosis, just swelling. So this swelling of IV fluid, of a normal saline, for example, is just producing swelling, transient swelling that is going to be easily resolved. But when there are some substances like chemotherapy, like dopamine, like the own TPN, okay, if it is extravasated, those substances are called vesicants and can produce a necrosis of the flesh where the liquid has been spilled. And of course, is a client that is going to be calling because there is pain in the insertion in the IV site, and you recognize that the fluid that is passing is a potential vesicant, and the intervention to immediately stop the IV fluid remove the tubing, but don't remove the IV catheter. You need to understand what is the difference between a tubing connected to the IV catheter. Yes. Okay. So remove the tubing, but not the IV catheter. You see why I leave the IV catheter if it is outside? It is outside the vein. Okay. Here is the vein. Here is the vein, and the catheter is outside, because all this liquid that has spilled and had the potential for necrosis is precisely at the tip of the catheter. So you can come with a syringe and you can suction with a syringe the highest amount of liquid and blood that you can retrieve from this extravasation, minimizing the the damage produced by the vesicles. Even after doing that, okay, ask the doctor, because sometimes there are antidotes, like for example, dopamine has an antidote, phentolamine, okay, to prevent this necrosis that you see here, okay. And usually cold compresses are recommended by the doctor to apply after this happens. Okay, so don't forget that makes sense to retrieve the extravasated vesicant with a syringe to suction that. The arterial lines are placed in the radial artery. You know, radial artery, the one that you use to take the pulse, and the one that you use to obtain blood specimen for ABGs. Okay. Doctors can insert a catheter this way inside the radial artery. Uh, the purposes are two. One, to direct measure the blood pressure. Is the most precise. The intraarterial catheter measure the intraarterial blood pressure. Is the most exact in critically ill clients in shock, etc. Okay, are being continuously monitored the blood pressure through a intraarterial catheter. The other reason is when there is need of frequent obtention of specimens of arterial blood for arterial blood gases, ABUs. This is the main reason. When you have a catheter inside the radial artery, you need to understand that it's not the same as a catheter inside a vein. In the veins, the pressure of the blood is low, very low. So the risk of bleeding is negligible, is very low. Um, when the catheter is piercing an artery, the pressure of the blood inside the artery is huge. So there is a possibility of a spillage of blood outside the artery. There is a possibility of bleeding. There is a possibility of a hematoma. So you need to observe for signs of bleeding. Any lump, any uh, bump that forms, there is a hematoma. Yeah. But the other possibility is that the possibility of obstruction of this artery by thrombosis. So you need to observe for sign of ischemia in the hand. The radial artery is used because usually people have as an alternative way of irrigation of the hand, which is the ulnar artery. That's why before this need to be done the Allen test. This test that allowed to verify the patency of the ulnar artery. Okay, and well, this catheter could be ordered by the doctor to be removed. You can remove that. So you remove the dressing with clean gloves. You put a gas and a gas over the side, and you remove the catheter. Observe if the catheter is intact. But now you need to make pressure there in the artery, at least for 5 minutes, because you need to understand that it's an artery. So you need to allow time for this little hole to close. So 5-10 minutes of pressure is needed. Uh, this is about another route of administration of medications. for example, the intramuscular route, you need to know the sites of administration of intramuscular shots. Is the deltoid. The deltoid is the muscle that we have in the arm that is localized on 2-finger breadth, okay, like 1.5 to 2 inches, 2 to 3 finger breadth below the acromion, the bone that we have here in the shoulder. This deltoid area allows only 1 milliliter of liquid, no more than 1 milliliter. Uh, cannot be used in infants because infants have this muscle not developed. Need to be mainly used in school age children and older. For vaccination is used mainly. The other is the gluteals. The gluteal have 2 gluteals, the dorsal gluteal and the ventral gluteal. The dorsal gluteal have a important nerves, very important nerve and blood vessels passing nearby. That's why Nclex doesn't like you to use the dorsal gluteal. So they prefer to use the ventral gluteal. For ventral gluteal, the clients must be in lateral position. Ventral gluteal requires the client to be in lateral position. And the point of reference is the major trochanter. The major trochanter that is prominent here in the hip. This is the place above this major trochanter is where you are going to localize the site for the insertion of the needle in this muscle. It is for the ventral gluteus. So if this is the major trochanter, you are going to touch with your finger, for your index finger, the iliac spine, the anterior superior iliac spine, and then behind this area, okay, you can make a V sign with the middle and the index finger. In this area is where the needle is going to be inserted. And the vastus lateralis, that is lateral to the thigh, midway between the knee and the major trochanter, that is the preferred site for small children. Of the technique of intramuscular, you must know that a long needle is needed. In children, 1 inch. In adult, at least 1.5 inch to be sure that you are inside the muscle. And the gauge of the needle need to be, thick enough as to provide the strength necessary to prevent the needle from bend, and the diameter, the gauge enough to administer liquids that could be a little thicker than usual. And generally between 21, 22 G are the adequates. In my experience, because I remember this question frequently in Nclex, that generally they put 21 G. That's why I insist so much in 21 G for intramuscular. You need to have an idea of the Z-track, which is a technique used for intramuscular only. When the liquid can stain the skin or irritate the skin, if the liquid comes back to the skin after being deposited in the muscle. You know that when you insert a needle, you produce a tunnel, a track, okay? And then the liquid is deposited in the bottom, in the muscle, no? The liquid can return through this track, through this tunnel, when you remove the needle. To avoid this from happening, what you are going to do is to pull the skin before inserting the needle. So once you deposit the liquid in the pocket, okay, in the muscle, you remove the needle and then you remove the traction that you were making in the skin. This is going to make the skin to return to the previous position, making a Z-shaped track that prevents the liquid from going back to the skin. When you are administering a medication that is requiring a Z-track, you need to change the needle. You cannot use the same needle that you used to draw the liquid. You leave a bubble of air in the syringe, and you do not remove the bubble of air. And then you pull, you clean, you pull, enter, inject, remove, and release the pressure. You avoid massage, you avoid pressure. For subcutaneous, of course, you need to use a much smaller needle. So the length with 3/8 of inch is okay, and the gauge very fine, 24, 26. When you inject in the subcutaneous, the tip of the needle is going to be in the fat that is under the skin, never in the muscle. So you need to make a pinch to be sure that you are in the fat before inserting the needle. Frequently in the Nclex, they ask you in which angle you can do a subcutaneous, a sub-Q injection. Okay, you can use 45 or 90 degrees. Be sure that it's a short needle, and be sure that you do the pinch. But you are going to use the 90 degrees if the client is fat, if the client has enough adipose tissue. If you find a very thin client, there are clients that are very lean, they don't have fat, and then when you make the pinch, you find little fat. It's better to enter at 45 degrees, because entering at 45 degrees, okay, you have less risk of reaching the muscle if you enter in 90 degrees, okay? Once you inject, you never aspirate in subcutaneous, because subcutaneous has not blood vessels that justify the aspiration. And if you start aspirating, you can produce trauma unnecessary, especially undesired if you are injecting anticoagulants. So you don't aspirate. And then after you inject, you remove the needle and you release the pinch. Please don't massage. Don't massage, okay? When you inject, okay, these okay, okay. Look at this question. The nurse observed an LPN administer iron dextran. Iron is one of the most commonly medication used in Z-track because can stain the skin. It is most important for the nurse to give the LPN which of the following instructions. Massage the injection site. No, we don't massage. Tap out the air bubble before administering medication. We leave the air bubble. Release the skin before withdrawing the needle. No, withdraw the needle first and then release the skin. So the right answer is change the needle after drawing of the medication. For blood products, you need to know that blood transfusion requires a doctor's order, but also a client's consent. There are many blood products. You have, for example, packed red blood cells that are given for patients with anemia, but also you have plasma that could be given. Fresh frozen plasma is given in coagulation problems when there is a need of volume expansion, etc. Both plasma and red blood cells requires the compatibility of the donor and the recipient. So the cross matching in the type of blood is needed for red blood cells and for plasma transfusion that are separated, because when you donate blood in the bank, they separate the plasma from the red blood cell. But there are two different transfusions, but for each one there is need of blood type and cross matching to be sure that they are compatible. For other products like albumin, coagulation factors precipitate, cryoprecipitate for platelets. You don't need on this ABO typing. The blood must be passed through a wide enough catheter, because otherwise it's going to produce hemolysis and destruction of the red blood cells. The recommended size is 18G. If for any reason there is a very difficult vein, very fine vein, etc., 20G is the maximum, but generally in Nclex they exist 18G. That's why when you are going to administer a transfusion, the first that you need to do before sending for the blood is to be sure that you have a good vein taken. You cannot send for the blood, and then when the blood arrives, I don't have the vein taken, I need to start, these veins are so difficult, and then the blood is going to be for too long outside the refrigerator and is going to spoil. This is not a good nurse. So the first to do is to verify that the vein is okay, 18G, and is patent. The vein should be receiving normal saline. No other IV fluid can be used simultaneously with a transfusion. If the patient is receiving other IV fluids, need to be changed to normal saline. The transfusions are administered with a special tubing. This tubing has a Y connection, Y shape, and has a filter inline to trap any possible clot coming from the blood. So first, okay, let me change just a moment, because I didn't want to, just a moment, I didn't want to draw, but I need to draw from current slide. So first, let me erase and erasing the blood. First, you are going to get the vein, and you have the vein, okay, connected with this special tubing to the normal saline. And then when you have this, what you are seeing now, because I erased the back of the blood, yes? This is hanging here, covered to avoid contamination. This arm is waiting for the blood, but you have the normal setting passing to the client, yeah, to the IV catheter. And then you send for the blood. When the blood arrives, is when you find another nurse, you double check that is the adequate blood for the client, you take the basal vital signs, and then you hang the blood, and you connect the blood. When you connect the blood, you need to close the normal saline. Close the normal saline here, and open the blood. Then the blood starts flowing through the tubing toward the client. This initial flow must be done very slowly, to verify that the blood is any reaction. So no more than 2 milliliters per minute. And then you are going to be checking the client during the first 15 to 30 minutes. Every 5 minutes, checking the vital sign to be sure there is not any adverse reaction. If there is no adverse reaction, now you just can speed up. So open the clamp to speed up the speed of the transfusion. The speed can be variables given by the doctor. Can be very fast, can be very slow, but the slowest is 4 hours. The blood cannot be more than 4 hours out of the refrigerator or the blood bank. No medication can be added to any of these bags. And of course, you are going to monitor for any adverse reaction. You must know, is Nclex question, that each bag of packed red blood cells, will increase the hemoglobin in 1 gram and the hematocrit in 3%. So, see, for example, you have a patient that initially has hemoglobin 9, yeah, 9, yeah, and receive 3 bags, okay, of packed red blood cells, okay, which hematocrit would have after the last bag is administered. So if they have hemoglobin 9 and you give 3 bags, it is going to increase to 12 hemoglobin, no? Because 1 gram for each bag, 3 grams, 9 plus 3, 12, yes? Hemoglobin 12. But then they are asking hematocrit. Multiply 3, 6, 3, hematocrit 36%. And the answer is 36%. A similar like these questions was in English. And then you'd have a box and you need to introduce the number of your calculation. You need to know your compatibility. So you need to know that O only receive blood from other O's. A can receive from A and O. B can receive from B and O. And AB receive for everybody. From A, from B, from AB, and from O. But a part of the ABO compatibility, you need to know the RH compatibility. You have two type of RH, present, which is positive, or absent. The problems are the negative RH. Positive have no problems because positive receive either negative or positive. They don't care if the blood is negative. They can accept negative blood. The people that are positive accept positive or negative, but the negative only accept negative. This is the case of a mother, Rh negative, that is rejecting the fetus blood if is Rh positive, and then can produce this incompatibility. So this is the most important that you need to know about transfusions and compatibility. Okay, guys, this is what the time has ended, and this is what I have for you today. Do you have any question?
Yes, Professor.
Thank you, Professor.
Go ahead.
So you say each bag of red blood cells give the
One
patient 1 gram of hemoglobin.
and 3% hematocrit, because 1 gram hemoglobin is 3%.
3% each bag. So if the patient was administered 3 bags, 3 plus 3, 9%.
No, 3 bags, 3 grams.
Uh-huh.
Yes, and then they are asking you how much increases the hematocrit. Okay,
Oh.
so you have 9 grams initially plus the 3 grams that are given at 12. 9 plus
Uh-huh.
3, 12.
12.
But those are hemoglobin, and they are asking hematocrit. How you calculate hematocrit? Multiply this times 3,
3, yeah.
and then you get 36%. So you say, oh, at the end of the 3 transfusion, the hematocrit should increase to 36%. So the end hematocrit should be 36%. And this was the number that you need to introduce in the box. You understand?
Okay. Perfect.
You got
Perfect.
it? Okay,
Yeah,
perfect.
got it. Thank you.
Okay. Okay, guys. So uh, this is what I have for you today. Let me people get the attendance and see you next time. They say this don't long attend. Yeah.
Thank you, Professor.
Okay. Good night.
Good night. Bye.
Thank
Good
you,
night.
Professor. Good night.
Good night.
Good night. Thank you.
Thank you.
you.